Dean of Duke Divinity School to give a brief welcome on behalf of the school. Dean Colon Emerick will then be followed by my colleague in Theology, Medicine, and Culture co-director Fark Herlin, who will describe the work of Dr. Tom Catena, for whom this lecture is named, and then we'll introduce Dr. Russell White. So welcome. Thank you for being here with us this evening.
Good evening, buenas noches. My name is Edgardo Colon Emerick, and I'm Dean of Duke Divinity School, and I want to welcome you to, well, Duke Divinity School. Duke Divinity School is a school of Duke University, and that is both obvious and significant. It's significant because here, as in the university's motto, we combine knowledge and faith. And that combination of knowledge and faith is exemplified in programs like theology, medicine, and culture that connects divinity and medicine and global health and partners with other parts of the university. As Duke Divinity School, we're also a school for the church. We are Methodist in heritage and yet ecumenical in our embrace. And that practice of being an ecumenical community means that we are very diverse in terms of the kinds of traditions represented here, but with a commitment to the church and to the church's flourishing. We're also a school in Durham, North Carolina, and that matters because our location, our zip code, roots us in communities with histories and with aspirations, with challenges, and that grounding for us means that our mission as a school has roots that reach out because we're a school with a worldwide mission. We are in North Carolina, and yet we are also reaching out around the world, and a mission around the world where we particularly lean into the places that are wounded, the places of marginality, that our faith is not simply in search of understanding, it's also mercy in search of understanding. And that is why today's lecture fits so well and encourages the Divinity School on its path. So welcome, and let us have a time together of reasoning and being renewed.
Thank you, Edgardo, and I also thank you for coming this evening. This is the third Thomas Catena lecture. Dr. Thomas, or Dr. Tom as he goes by, Catena, is a remarkable human being who for many years has been the only physician in an area of the Nuba Mountains of Sudan with roughly about 1 million people. And trained as a family physician after completing his medical school here at Duke University. Dr. Catena works with colleagues at Mother of Mercy Hospital in Nuba, where one of our fellows, Pfeiffer Nicholson, just returned from, being there for the last couple of months. We, in this lecture, try to bring someone to Duke who exemplifies the intersection of medicine, faith, and service, that's committed to practicing medicine with integrity in the pursuit of healing for the people to whom they are giving their lives and directing their efforts, that does that in a way that is grounded in and inspired by the Christian faith, and again, in a way that shows a spirit of service to our neighbors. And we're delighted this year to have Russ White with us, Dr. Russell White. Dr. White was born to medical missionary parents in what was then the Belgian Congo. He grew up most of his life, though, in the United States, went to Roberts Wesleyan College, graduated from medical school at the University of Michigan, and then went to Brown University, where he completed general surgical training, and then went to England, to Bristol, where he completed a fellowship in cardiothoracic surgery. And shortly after that, Dr. White moved with his family to Tenwick Mission Hospital in Bomet, Kenya, where he has been the chief of surgery since 1997. And I won't say much more about the roles he's had there, because I think they're going to come out as Dr. White tells his story. But it's really been a remarkable season of developing efforts to train Kenyan and other African physicians at Tenwick and to develop a remarkable new center in cardiothoracic surgery that he's going to tell you about. Dr. White has been awarded, won the Humanitarian Surgeon of the Year award from the American College of Surgeons. He received the Surgeon of the Year award from the the Surgical Society of Kenya, as well as the L'Chaim Prize for Outstanding Christian Medical Mission Service from the African Healthcare Mission. So join me, if you would, in welcoming Dr. Russell White.
Well, thank you for this distinct privilege to stand before you here at Duke. This is my first time to Duke University, and I'm very pleasantly surprised to meet so many like-minded people, and it's been a pleasure of mine to spend a few days with you, and particularly you students in the TMC program. It's just been a real pleasure to interact with you and see how you are seeking God's will in your life and learning and exploring what that might mean. I've been working for the last 25 years at Tenwick Hospital in Western Kenya as a medical missionary. And I want to share with you what has motivated me to do this, to take my family to a place far away and serve in a completely different people group in a very different environment than I was used to here in the United States. I think in order to do that, for you to understand me a little bit, I need to tell you a little bit about my worldview, my philosophy, my theology, what has led me to do this. So let me begin with a simple question. What does it mean to be human? What is it about us that we say we are human? My answer to that, personally, is rooted deeply in the Judeo-Christian heritage of the Old Testament. To be human means that each one of us bears within us the image of God. In Genesis chapter 1, we read that after God created everything else in creation, he said, "Let us create man in our own image." And so God created man in his image. God, is, we all know, is the omnipotent, omnipresent, omniscient creator of all. And he has placed within each one of us an image of his nature. Therefore, we think and we reason. I think the philosopher Descartes was trying to get at that a little when he said, "I think, therefore I am." So we think and we reason, we dream, we plan, we strategize, we love, we hope, we judge, we condemn, we build up, we tear down. In all of these and so many other ways, we demonstrate the image of God within us. I also agree with the paraphrased words of Blaise Pascal, the famous mathematician from France, who said, "There is a God-shaped vacuum in the heart of each man, which cannot be satisfied by any created thing, but only by God the Creator, made known through Jesus Christ." The United States has changed a lot since I've been out of the country. Things are really very different in many ways. But what's not different is I see people chasing after man-made things to bring them ultimate joy. And that's a recipe for failure. Because there is a God-shaped vacuum within each of us that can only be filled by our Creator made known through Jesus Christ. There is a desire in each of us to know ultimate truth and meaning, and a knowledge that our existence goes beyond the purely physical. That too is part of being human. You know, there are very few atheists in my experience in Africa. Atheism is a distinctly Western disease from my perspective. While we may disagree in Africa about the nature of God, maybe at times vehemently disagree, there is general agreement with the metaphysical truth that we are more than just the sum of billions of cells. We all have a spiritual nature as well as a physical nature. You don't have to convince most Africans of that. That's understood, as Paul describes in the book of Romans. It's understood by the things we see that we have a spiritual nature. So all humans bear the image of God and therefore have innate value. This sets humans apart from the rest of creation. We were created to have relationship with God. That's what we see in the creation story. We were created to have a relationship with God and with one another. The idea of being a solo Christian is not a biblical concept. We were created for community and relationship with God. So when an individual suffers, or a group of people suffers, or a geographic area of people suffer, we are all to a greater or lesser degree devalued. But we must remember that we live in a world that is far from perfect. What God created was good and perfect, and we still see the glory of God all around us each and every day. We see the majesty of his creation in every sunrise, in every sunset, in the smile of others, in the joy of working together for common good. I see it every time I see a heartbeat start up again. When we do open heart surgery, we stop your heart. We do that with a drug that we instill in the heart. It's essentially the same drug that's used for lethal injections, but we keep it only in the heart. And at the end of the case, when we're finished doing our work, many people think we have to flip some switch or shock something, or we don't have to do any of that. Off and let the drug get free of the heart and let the normal blood come back into the heart, and the heart starts beating on its own. It's a remarkable thing. It never gets old. Every time I've seen it thousands of times, and every time I see it, I'm amazed at what God does, that this heart starts beating on its own again. But we must remember that this world has been tainted with sin, and this affects every area of our lives. And so we see war and famine and disease. We see poverty and rape and murder, and we see substance abuse and sexual, gender, and racial harassment. We see prejudice and lying and cheating and gossiping and rumor mongering, and the list goes on and on and on. And these are the very reasons why Christ himself came to earth and died on the cross of Calvary that we will celebrate in just a short time from now, to redeem us from this mess. In that same vein, I've always been motivated by what Paul calls in the New Testament a ministry of reconciliation. So in Colossians we read, "For God was pleased to have all his fullness," that is, all the fullness of God himself, "dwell in him," that is Christ, "and through him to reconcile to himself all things, whether things on earth or things in heaven, by making peace through his blood shed on the cross." So God has reconciled all things to himself through his work on the cross. But then we read in 2 Corinthians, "All this is from God, who reconciled us to himself through Christ and gave us the ministry of reconciliation." That God was reconciling the world to himself in Christ, not counting people's sins against them, and he has committed to us the message of reconciliation. Each and every one of us is called by God to be involved in this ministry of reconciliation. Seeing that God is reconciling the world to himself, he has now given us that ministry here on earth. So to what end are we to reconcile? Well, spiritually, this implies we take the message of the gospel of Christ to the world. And the message of the Christian faith is a unique message, that God himself took on the form of man and became completely human and sacrificed his life on the cross of Calvary. This is distinctly Christian and distinctly different than all other religions, and it's the message that we need to take to the world, and we must never be ashamed to proclaim that to the world. But what about physically? Remember, Paul said in Colossians, he was pleased to reconcile to himself all things, whether things on earth or things in heaven. What about physically? And that brings me to the concept of shalom. Shalom is a common Hebrew greeting, which has generally been interpreted as peace. We think of it as peace. Now, while shalom does have a connotation of peace, it really means so much more than simply peace. It comes from the Hebrew word shalom. It's used for the first time in the Torah in Exodus chapter 21 and 22, where in that segment of Scripture it's used 14 times. And in those passages, Moses is giving instructions to the people about what to do when someone causes material loss, or in the case of theft of property. When that loss or injury occurs, the owner is considered lacking or not complete. And the one responsible was to make things right. So in this setting, the interpretation would be to restore or to make something right. A better definition of shalom when used as a noun would be the way things ought to be from God's perspective. Shalom in its fullness means the way things ought to be. When it's used in reconciliation, then, it is to restore things to the way they ought to be. This does not just mean restoration of property, but rather implies a sense of wholeness and completeness. So reconciliation means working to reorder things to the way they were meant to be. We can reorder our priorities and relationships. We can reorder lifestyles and personal practices. We can reorder forgiveness and mercy. And we can reorder the way in which we provide medical care across the globe. And this ministry of reconciliation applies to the physical as well as the spiritual realm. So every time we perform a coronary artery bypass graft, we are attempting to reconcile things to the way they were meant to be, to bypass the blockage that is present. Every time I replace a destroyed heart valve in a child with rheumatic heart disease, we are reordering things toward what they were meant to be. So why did I choose to spend my career working in Africa rather than staying in the United States, where the salary, ability to spend time with my extended family, and the general convenience of life is so much better? Well, things affected me. Did you know that in sub-Saharan Africa, 25% of the world's health care needs occur in sub-Saharan Africa? However, less than 1% of the world's health care resources are spent in sub-Saharan Africa. This is not shalom. This is not how things were meant to be. Did you know that according to the WHO minimum standards for surgeons across the world, that in the country of Malawi in southern Africa, they have about 4% of the minimum number of surgeons required to take care of their people? While in the United States, we have 267% of the number of surgeons we need as a country. This is not shalom. This is not how it was meant to be. Did you know that there are approximately 37 million people living in the world with rheumatic heart disease? The majority of them reside in sub-Saharan Africa, and 12.5% of them will die every year. 37 million patients, most of them between the ages of 5 years of age, and 30 years of age. 37 million. let's put that into perspective. That's about the same number of people who are living with HIV/AIDS in the world today. The number of patients with HIV/AIDS is equal to those with rheumatic heart disease. Now think for a moment, if you will, about the amount of resources that have gone into understanding HIV and providing effective treatment for HIV. Hundreds of billions of dollars have gone into it, and successfully, so that nowadays HIV in many ways is a chronic illness which can be managed for a normal lifestyle and a normal lifespan. When was the last time you saw a commercial on television for rheumatic heart disease research? When was the last time you heard of a program aimed at decreasing the incidence of rheumatic heart disease? Probably never. Why? Because it doesn't affect us here in the United States. Rheumatic heart disease tends to be a disease of the lower middle income countries, and it has allowed rheumatic heart disease to become one of the neglected conditions in the world. This is not shalom. This is not how it was meant to be. When we first visited Kenya in 1992, there was a single surgical residency program in the entire country that was graduating usually 4 surgeons per year. 4 surgeons for a country of 45 million people. That doesn't even keep up with the death of current surgeons. This is not shalom. This is not how it was meant to be. These facts and figures, and many like them, haunted me through my undergraduate and graduate medical education years and were fundamental to my commitment to spend my career serving in an underprivileged area. I was very moved in medical school by a simple word picture put before me by Tom Hale, who was a surgeon in Nepal for many years. And he said very simply, if you come across a group of 10 men carrying a heavy log, and 9 of them are on one end of the log, and 1 of them is on the other end, and you want to help, where will you go? It was simple. The answer is obvious. This is a real log, by the way, in the picture, and those are some of the residents that I teach and train, and the one standing alone, our young female resident, we had to take the picture quickly because her knees were starting to buckle with this really pretty big log. She has just completed general surgery, pediatric surgery, and now cardiothoracic surgery, and she's one of our board-certified cardiothoracic surgeons in Kenya. So I was moved that we needed to go where one person was holding up the log. I told Far Curlin I remember distinctly as a medical student in the University of Michigan, I think it was during an OB rotation because we were kind of waiting for things to move ahead, and we were in this surgeon's lounge, and I was looking through the yellow pages. Again, many of you younger people don't even know what the yellow pages are anymore. And I looked up surgeons in Ann Arbor, and there was page after page after page after page of surgeons. And I thought to myself, I could be the 1,001st surgeon in Ann Arbor and work to make a difference. Or I could go somewhere where I'm one surgeon helping 1 million people. And where would the bang for the buck be? It seemed to speak very clearly to me. So in my 4th year of medical school, my wife and I took an away rotation to Sierra Leone, West Africa. And working there in a small mission hospital in a very remote location, we were able to see firsthand the difference that one doctor could make to a very needy community. However, I was also struck by the fact that the longevity of the impact on this community was based solely on this single doctor's ability to remain in Sierra Leone. In fact, when civil war struck that country, this American doctor was forced to leave, and the hospital ceased to function until today. It seemed to me that to make a long-lasting difference to low-resource areas, the training of professional national staff would be key. And so I began to seek for a place to realize these dreams of postgraduate medical and surgical education. And when I asked the question broadly within the mission network, where can I go to be involved in a mission hospital that is involved in training people at the residency level? The answer was nowhere. Nobody's doing that. This was in the late 80s and early 90s. But if you want to do that, you should put yourself in a place that's a little larger hospital. You can't be doing this at a one-man clinic. And the name of Tenwek Hospital kept coming up in conversations, that this hospital was poised to be able to do this. They already had a nursing school that was actively training nurses, and perhaps they would be interested in training doctors. So we went in 1992. I took time off after my second year of surgical residency and obtained a master's degree in public health from Harvard. And during the second year of my time away from residency, my wife and I, with our 12-month-old son, traveled to Tenwek Hospital. And it's interesting, my wife, who had been on board with the whole idea of long-term service in a low-income setting, became quite concerned at this juncture. We had a 12-month-old son, and we were heading into deepest, darkest Africa. And what would that mean? Her thoughts at that time were perhaps we should wait until it's a better time in our life to do this. And I said, when do you think will be a better time? We have a 12-month-old. I think we're going to have more 12-month-olds as we go along this path. And that is what happened. I had 5 12-month-olds over a period of a number of years. But she agreed and trusted in the Lord, and we went to Tenwek Hospital in Western Kenya. Throughout those 7 months we were there, we felt like it was a good fit for us, and we felt that God was putting his hand of blessing upon this. In fact, it was the first day I was at work and found myself facing things I had never seen before. Came home at the end of the day and said, I got to read a lot to keep up with things. You couldn't Google anything. There was no Google. You could read at the books in the medical library. But I wanted to know what she thought. I wasn't entirely sure. What do you think of this? And she said, I believe this is where God is calling us to serve. And that was a real blessing. That was a turning point for us. And we were able then to come back, finish my residency, and do my fellowship training with a renewed sense of purpose and direction, and were able to raise the necessary support and financial backing to return to Tenwek full-time after I completed my fellowship. So during my first year at Tenwek Hospital in 1997, I came and I was one of 2 surgeons. There were no specialty surgeons of any type. So suddenly I was confronted with the fact that I was now the orthopedic surgeon and the urologist and the plastic surgeon and the neurosurgeon and the gynecologist. And these were not things I had been trained in, but these were what patients were presenting with. And we began training. Tenwek Hospital sits in the western highlands of Kenya. It's really a beautiful area. It's very green, gets a lot of rain. It sits essentially on the equator, but because of its elevation, it's very temperate. So daytime is 75 to 80, and nighttime is 55 to 60. It's really kind of beautiful. I get tired of nice weather. I grew up in northern Michigan, where snow was a big part of our lives. But if you have to choose one climate, the climate at Tenwek Hospital is pretty nice. So we began, and we approached the government about approving us as an internship training program. And internship is a 1-year rotating internship in Kenya that is required by the government of all graduates of medical school. At that time, in 1997, only about 1/3 of Kenyan doctors were doing residency programs. The rest would do internship and then function as a medical officer at one of the hospitals. That's changed a lot, and many more residency programs have opened up since then. But at the time, we began with internship training, and we began with 2 interns, And that rapidly expanded to 4 and expanded to 8 interns and expanded to 12 interns and on up to 20. So we had 20 interns. And then in 2002, family practice was the first residency program that we started. General surgery residency began in 2007 and was rapidly followed by orthopedic surgery. So by 2014, we were graduating 3 family practitioners, 2 general surgeons, and 2 orthopedic surgeons every year from our program. Now, we come to the issue of heart surgery. Heart surgery in rural Africa? Really? Is that something we ought to be doing? I was personally very skeptical of it. In fact, on one of his visits to Tenwick Hospital, Franklin Graham of the Samaritan's Purse organization talked to me and said, "How about building a heart hospital here at Tenwick?" And I said, "No." I said, "That's a bad idea. I don't think we should do that." We fast forward, what are we doing now? We're building a heart hospital at Tenwick Hospital. This year, we're planning to finish it. But I felt like it was not something we ought to be doing there in Kenya for a number of reasons. One, it tends to be an expensive undertaking. You need a lot of gear to make it work, a lot of equipment to make it work. You need a lot of human resources to make it work. It's not a one-man show. It's much more of an orchestral undertaking to have all parts involved in this. And secondly, I thought we just don't see the patients, the number of patients that would justify doing something of this magnitude. We don't have McDonald's in Kenya. We don't have people filling their coronary arteries with monounsaturated fats and all the rest. Now, it's coming, and there's a westernization taking place, and in Nairobi, there's certainly more frequently coronary cases. But I was just saying we don't see what we see in America. No, that's true, but we see other cases. So this particular young man who's 15 years old, but he looks a little young for his 15 years, and he does look young, and that's because he's been struggling with congestive heart failure for several years now. He noticed years ago that he couldn't keep up with his colleagues in physical education at school, and eventually had to drop out of PE classes. Pretty soon he found he couldn't even walk to school. He was too short of breath to walk to school and had to drop out of school altogether. I see 3 or 4 or 5 of these patients every single day show up to Tenwick Hospital in greater or lesser degrees of extremis. This is the face of heart disease in Africa, in the place that I work. We have currently, there's about 650 patients on a waiting list for rheumatic heart disease surgery at our hospital. There's another 400 with congenital heart disease waiting on a list. We'll never get to those. Every week, some of those die. We can't prevent that because we're limited in what we can do. So it took a lot of convincing on my part. We had a pediatrician who was at Tenwick from 1969 up until the early 2000s. And he would call me at night. 2 o'clock in the morning, I'd get a phone call from the pediatrician. He'd say, "There's another rheumatic patient dying. Do you want to do surgery on him?" I'd say, "No, that's a bad idea. I mean, we didn't have the setup to do that. That's a guaranteed death if you do that." But he kept knocking on that door, and it seemed like the Lord opened avenues. We started off very humbly. Before I show you that, let me put how common is rheumatic heart disease. Again, it's nearly non-existent in most high-income countries. It's 37 million cases. Most of them are what I put there. How common is it compared to other diseases that you might see here in the United States? Well, in 2018, breast cancer, there were 266,000 new cases of breast cancer. In that same year, in all cancers worldwide, there were 18 million new cancers worldwide. All patients with HIV, as I mentioned, 37 million, and rheumatic heart disease, the same, 37 million. It's something we just don't see, and since it doesn't bother us here in the United States, we don't do a lot about it. Again, about 12.5% of these patients will die every year. So we started very humbly in cardiac surgery. I had a friend who's a cardiac surgeon in Providence, Rhode Island, who was over in Kenya visiting another hospital and came down and spent some days with us there. And sure enough, several kids showed up with rheumatic heart disease. And some of these kids had pure mitral stenosis. Now, that's not the most common presentation of rheumatic heart disease. In fact, it's only about 3 to 5% of patients that will have pure mitral stenosis. So they have a mitral valve between their atrium on the left side and the ventricle that is too tight and not allowing blood to flow through. So you can open that valve. You can open that by this technique, which is a 1950 drawing from a Netter volume of the old-fashioned open chest, closed heart mitral commissurotomy, whereby you put a finger in the atrium of the heart and put a dilator in the ventricle and crack open that valve. And I'll tell you, it's a bit of an anxiety-provoking operation. There's no backup. You know, it's like doing the high wire with no net whatsoever. If things go badly, they're going to go badly and you can't stop them. But we did. We went ahead and did these cases. It was really very interesting. This friend of mine said, you know, we need a Tubbs dilator. I wonder if we have a Tubbs dilator anywhere. And I kind of smiled. I said, you know, when I finished my fellowship in England, they had a dinner for me, and they gave me a gift. The gift was a Tubbs dilator. It was meant to be a museum piece that goes on your bookshelf in your office, and that's exactly where it was, on the bookshelf in my office. And I took it down and dusted it off, and we washed it and sterilized it and took it into the operating room and performed this. This was the first heart case ever at Tenwick Hospital. That's my son in the background. He was, I don't know how old he was at the time, 11 or 12, watching the first heart case. He was excited to see that. And that's the Tubbs dilator on the Mayo stand there. And that's what it looks like when it's open. That's that patient, the first patient we ever did, 2 days post-op, getting ready to go home with a new lease on life, able to now not find himself in congestive heart failure, able to be managed quite well with medical therapy. In many of these cases, they'll need an intervention again at some point. Not all, but many. They'll need a mitral valve replacement probably in the future. But this can get them 10, 12, 15 years of time. And he was the first one. We went ahead and did a number of these cases. We did have one death in our first 15, but we felt pretty good about this. And we thought we need to move ahead with open heart cases. Now that involves getting a lot of equipment to Africa, which we were able to do. And God seemed to open the doors that this equipment could come in. And so we started. We almost never use that technique anymore, the closed chest mitral valvulotomy. Every now and again we will. So here's an example. This is a chest x-ray of a woman who's 24 years old and 24 weeks pregnant, in extremis with congestive heart failure. Now, to put her on heart-lung bypass and replace her heart valve runs a huge risk of losing that baby. So instead, we did this old-fashioned procedure on her. And that's her chest x-ray the day after surgery and the day she was being discharged. And that's her in our clinic when she came back to see us with her beautiful newborn baby to thank us for what had been done. So we don't do that operation very much anymore. It can be done with balloons and things. I see Jerry Bloomfeld here, and some of his colleagues would pass a balloon through that and open it up. But we moved ahead to open heart cases, which means bringing a lot of equipment in, finding ways to get that into the country, and then undergoing a lot of training. That's a heart-lung machine in action, taking all the blood from your body, oxygenating it, putting it back in. So we take over the function of your heart and your lungs during that procedure. But this took a lot of training. We had multiple teams visit from the United States that would work with our staff. And we talked about this in some of the classes earlier today and yesterday here at TMC, that I was really very specific with these visiting teams, that the role and the goal of them was to teach and train our staff. You know, they could come and do a bunch of cases in a week and go home, and that would make a difference to that group of patients. But if they were able to teach and train our staff, we would make a long-term difference. So we put a lot of valves in patients. That's a mechanical heart valve getting ready to go into the open heart case with all the sutures in place and the valve now in place in the mitral position. And that's a routine operation now. So we started with visiting teams in 2008. By 2014, we were self-sufficient. We were independent with adult open heart surgical cases. We still have teams who come, but things have changed. They spend time teaching our fellows and our trainees, and we really feel fairly self-sufficient for adult surgical cases. And our trainees, this person operating is the same one who was holding the log up. She's still with us, and she's, again, one of our board-certified cardiothoracic surgeons now. But teaching and training, working with them to see what they were able to develop, and this is something that Jerry would be very familiar with, doing echocardiograms on these patients. And our cardiac surgeons are pretty good echocardiographers as well. They have to be in what they do. And taking care of patients postoperatively. And then we moved into the congenital phase. So this is a small baby, as you can see, with the heart open, the chest open to deal with. That's the other major population group we see is congenital heart disease, patients with congenital conditions. And so we started again with teams coming to help and sewing a patch in a ventricular septal defect, and again having our residents and our fellows learn about this and get involved in this. We're not at this point totally independent from pediatric perspective. We still depend on teams, but we're getting there. And I think Dr. Odera, the young woman you saw who has a passion for congenital disease, will be our congenital heart surgeon in a few years from now. I think she'll be Times Woman of the Year. When she does that, will be a phenomenal heart surgeon there in the sub-Saharan African continent. So we see many little children who now undergo heart surgery at Tenwick, and seeing their bright eyes. Here's a girl from Somalia who came down, and if you look at her hands, this is kind of a classic picture of clubbing and cyanosis of the hands. She's got blue fingers, and her fingers are clubbed from years of living with a tetralogy of Fallot. We were able to repair that, and that's her fingers immediately post-op. Dramatic change from blue to pink when you give oxygenated blood to the body. 3 girls who all had rheumatic heart disease operated on the same day. Different camps that would come, and these are 1 week worth of patients undergoing heart surgery there, and another group, and another group. It's really gone on and on, so that now we are the largest provider of open heart surgery. The largest single provider in Kenya of open heart surgery is Tenwick Hospital. We've run into some bottlenecks. Things have gotten crowded. This is a real picture from years back. This was the neonatal intensive care unit. And it was busy and crowded. And even the wards would get busy and crowded, and we would have 2 or 3 patients on a bed. We've changed that. We've upgraded our practices, and we only have 1 in a bed. And in the NICU, there are 1 baby per bassinet and warmer. But that problem of crowding has really affected us severely. We have we built the new surgical building back in 2004, and we put 5 ORs in it, and I thought we'd be set for many years to come. Well, we rapidly outgrew that, so that now, cardiothoracic, we have 1 operating room 4 days a week. That's all we have, and 800 patients waiting to get in. It was obvious we needed to do something different, and so we started a couple of things. First of all, looking at human resource training. In 2018, we began the first cardiothoracic surgical fellowship within the College of Surgeons of East Central and Southern Africa sphere. So far, we've graduated 4 board-certified cardiothoracic surgeons. 3 of them are with us. 1 is in Zimbabwe working, and we'll graduate another one at the end of this year, and we'll be graduating cardiac surgeons every year as we grow. So this is our team of residents and fellows involved in the Open Heart program, and these are some of our graduates. The one at the bottom, Dr. Araga Fakadu from Ethiopia, was our first graduate, and he joined me on faculty, and it was an absolute blessing. He's a wonderful Christian man. He's an extremely gifted surgeon, and to suddenly have a partner after never having had one. I'd been 12 years with every night call and every weekend call, and suddenly I had a partner who I could trust and talk to and bounce ideas off of, and it was just a tremendous blessing to welcome him in. His first day, he said, "Now I'll take call for 10 years." And I said, "No, that's a really bad idea. I think you shouldn't do that. You'll burn out for sure. Let's work out an amicable agreement here about how we'll do this." But then we obviously need further space for what we can do. So about 3-4 years ago, we started a plan of a new cardiothoracic center at Tenwick Hospital. And these are some of the drawings of what that center will look like. The building began back in July of 2021 with groundbreaking, and it was a 2.5-year build, which takes us to December of 2023. And so very rapidly, this is a big facility. This is a 400,000 square foot facility with 5 operating rooms, a hybrid operating room, 2 cath labs, full endoscopy suite, 32 ICU beds, and 170 total beds in the hospital. So it's a significant undertaking. Will be the largest cardiothoracic unit in sub-Saharan Africa. And we saw it starting to come up month by month as the construction crew was working, up to 4 levels on, well, actually 5 levels on one side and 7 levels on the other because of the pitch of the hill. Seeing that come up to life has been really amazing. In the background there, you see apartments. Those were apartments we built for the residents and fellows in their training. And these are much more recent pictures with the siding coming on to the building and the roof coming on. And again, these are drone pictures taken just last week of what things look like there at Tenwick. And again, the housing units that we've built and our fellows and residents are living there. And it's very close accommodation to the hospital, so that when we open this fully furnished thing, the people working at it will be very close to what they need to do. I would like to transition just a little as we close and ask you, how does God speak to you? How does God speak to us? How many of you have, at some point in your life, pleaded with God to tell you what to do? If you'll just tell me what to do. Should I marry her or not? Should I take this job or should I take that job? And we plead with God and we say, God, just tell me. If you would, why do you hide your will from me? If you would just tell me, I would do it. I would gladly do it. And we seem to think that if God would do that, we would be all set. Well, you only have to look in the Old Testament to see the Israelites wandering for 40 years. They had a pillar of cloud by day and a pillar of fire by night. a pillar of fire in the sky over their camp. No question they were where God wanted them to be. When the pillar moved, they would move. And so they never complained, right? They always followed the Lord Jesus, or the Jehovah at that time. No. They had the Word of God before them every day, and they still complained. And we are pictures of that. Sometimes God speaks to us like that, every now and again. I remember when I was at Tenwick, and I'd only been there a year or two, and they called me about a child who was having trouble breathing, and I came up to the hospital, and there was a 3-year-old child who the mother said had been in perfect health until that day. She was out playing, and she was playing where they dry the red beans in the sun. And she came back into the house very short of breath and with great trouble breathing. And immediately we all thought she's probably aspirated a bean. That's what's going on with her. And she was in not good shape. Her oxygen saturation was very low. Her heart rate was very high. It didn't look good. What you need for that is a rigid bronchoscope to take that out. We didn't have one. We didn't have a rigid bronchoscope. What we had was an old-fashioned esophagoscope, rigid esophagoscope, with no light source whatsoever. No, you're supposed to have nice, fancy fiber optics and be able to see what you're getting at. We didn't have any of that. We had what essentially was a rusty old metal tube that we could use. And I talked to the mother, said, we will try our best, but I can't promise you anything. I don't know what's going to happen here. We took her to the operating room, and we started to put this rusty old tube down her throat and shining a flashlight in the end to try to see, and we couldn't see anything. We're blindly grasping, and as we do this, her saturation drops lower and lower, and then her heart rate drops lower and lower, and then she arrests in front of us, and we pull the tube out and do CPR, and we get her going again, and then we tried it again with the same result. And then we tried it again with the same result. Finally, I said, this is just not going to work. We can't do this. We'll have to try to open her chest and get this out from the inside. But I knew that takes a while to get to that spot, to get to the carina of the trachea and pull that out from the inside. I thought, she's never going to make it. We'll never get her through this. So I went out and was washing my hands. I told them, start prepping her for surgery. Let me wash my hands. I was washing my hands when God spoke to me. Really, literally. I mean, almost to the point that I responded verbally. I was washing my hands and I looked up and I said, what do you mean, try again? Have you not been paying attention here to what's gone on? We have tried. We've tried our best and it's not working and I can't save this child. And the Lord seemed to say, you're right, you can't. So go back in there and try again and let me work with you. I walked back in the room. They were putting all the equipment away. I said, get the scope out again. We're going to try again. And they said, that's foolish. And I said, look, I've already had this conversation with somebody higher up the chain than you. And we're going to try it again. As I walked in the room, there was an instrument sitting on the table. I don't know to this day why it was there, because only I would have put it there, and I didn't put it there. It was a ureteral stone basket. It was sitting on the table. Now, the route you go to get a ureteral stone out is a little different than you go to get a foreign body out of the trachea, but the principle is somewhat similar. So I grabbed this scope, we put it down, the oxygen starts to drop, the heart rate starts to drop, and I put this ureteral stone basket, just blindly shoved it down there and opened it and closed it and pulled the whole thing out, and there's a red bean in the basket. And her sats come up and her heart rate comes up, and eventually she woke up in the operating room, and many people had come to the OR now to try to help, and a cheer went up from the whole group. We don't cheer in the operating room that often. And one of the people there said it well. He said, I'm so glad that I could be here today to be a part of what God has done in this girl's life. I went out and talked to her mother. I said, for some reason, God has, through his son, Jesus Christ, our motto of our hospital is we treat and Jesus heals. I said, Jesus has saved your daughter. It certainly wasn't me. That woman fell on her knees and gave her life to Christ. It turns out that woman was running a still out in the brewing illegal alcohol. That was her livelihood. We sent a chaplain to follow up with her, and he came back with a glowing report. He said, that woman, the women of her village have welcomed her into their Bible study fellowship. She had them all over to break down her still, and she's working with them. It's a tremendous story that the Lord did through this little girl's life. So sometimes God does speak to us directly like that. But I don't think that's the most common way. I don't think that's, at least for me, it's not. I haven't had that many experiences like that. I think God speaks more often like he spoke to Jonathan in 1 Samuel chapters 13 and 14. And in that passage, Israel is at war with the Philistines, and the Philistines vastly outnumber the Israelites. And no one knows what to do. Saul is king. Jonathan is his son. In fact, in all the army of Israel, only Saul and Jonathan have a sword. No one else has a sword because the Philistines have put restrictions on them. And so Saul takes his group of 2,000 men one direction, and Jonathan takes his group of 1,000 men another direction. And it says Saul is losing men by the droves. They're running away because the Philistines are as numerous as the sands on the seashore, is how it puts it. Vastly outnumbered. No one knows what to do. Saul himself breaks God's command and offers a sacrifice, which only the prophet Samuel was supposed to do, trying to keep his men there. It's a famous line where Samuel comes and says, "What have you done? You've really," and that's the point at which he tells him, "Your house will not be on the throne. God has somebody else in mind." But Jonathan, with his men, it says in chapter 14, Jonathan goes out with his armor bearer one morning, and they pass through an area where there's two cliffs, and there's the Philistines up on this cliff. And Jonathan says to his armor bearer, "Let's go and see what God can do with us." Nowhere in the passage is it stated that God told Jonathan specifically what to do. Jonathan saw a situation that he had some gifts and talents that he could put to use. He was vastly outnumbered, but he said to him, "Let us go and see." And so in that passage, he said, "We'll go show ourselves, and if they say, 'Come up,' we'll take that as God's leading and we'll go up. If they say, 'Stay down,' we'll stay down." And they go out, and the Philistines say, "Come on up here." So they climb up with their armor, and Jonathan defeats all 20 Philistines. And that's the turning point in the conflict between the Israelites and the Philistines. Jonathan saw a situation, a need. He had gifts and skills which could be put to use for that. And he said, "Let's assume God is wanting us to do this. And if he doesn't want us to do this, he'll direct us a different way." I think God speaks a lot more commonly in that particular way than he does speaking to us directly. Jonathan saw this need, possessed the necessary skills to address the need, and being vastly outnumbered, he went and followed what he thought the Lord was doing. In Kenya, I saw a need. I had some of the necessary skills to just begin to address some of these problems that I saw. And I went forth in faith that God would bless our endeavors. Now, this is not to imply that we should not earnestly in prayer seek God's will. However, I feel that many people in the world are simply controlled by inertia, by the laws of inertia. You remember those laws? A body in motion tends to stay in motion unless acted upon by another body. Or, easier put, a body in motion stays in motion, so that this truck driver forgot that law of physics when he applied his brakes really quickly and what was in the back kept going. But the opposite is true as well. A body at rest tends to stay at rest. And I think many of us are controlled by this law of inertia. We tend to be at rest and we tend to stay at rest. Now, if you see a boulder like this, it has tremendous kinetic possible energy. But it takes a bit of work to get it rolling, to get it moving down. If you can get it moving down that hill, you will have released a tremendous amount of energy. So setting this boulder in motion for us has allowed us to progress from a handful of interns to a full residency training program in general surgery, orthopedic surgery, neurosurgery, and cardiothoracic surgery. Just last year, they started OBGYN residency training at the hospital. To the training of cardiothoracic surgeons and producing really world-class surgeons. I'll tell you, these surgeons are excellent. I have let them operate on me before. They are good, really very, very good. You've heard the old adage, give a man a fish, and you feed him for a day. Teach a man to fish, and you feed him for a lifetime. We're doing a bit of that at Tenwick Hospital. What does the future hold? Tenwick is rapidly becoming an international referral center for patients with cardiothoracic disease. And in all of our endeavors, I'm reminded that we need to go where the needs are great. Where will you go? Where is God calling you to make a difference? As we see what can be done with working to bring about change. This was our total group of residents and fellows just this past year, moving from 2 interns to a group like this. What does the future hold? In all our endeavors, we will continue to uphold our threefold mission statement at Tenwick Hospital, that we are a Christian community committed to excellent, compassionate health care, committed to spiritual ministry, and committed to training for service. Asante Sana. Thank you very much for your warm attention.
Thank you, Russ. We have an opportunity for you to ask questions of Dr. White. We have a couple of our TMC fellows who have microphones. As you're thinking about your question, we, again, welcome that. Let me ask you, Russ, I thought you had a compelling vision for reconciliation. I think, at least for me, growing up in the U.S. as an evangelical, and in fact going to Tenwick as a 19-year-old with my dad, would think of reconciliation, and the only thing that would probably come to mind is that people would have a spiritual conversion. Wasn't thinking about that, the making right, making as things should be, shalom, that which is broken. When you look ahead, you told us today you're in your late 50s. When you look ahead 10 years, 15, 20 years from now, what would shalom look like to you with this work at Tenwick down the road?
Sure. I think shalom will look like these young colleagues of mine in charge. I don't intend to be in charge for that period of time. That'll be their ministry. I'm not sure how many years God will give me. I'm not heading to the graveyard yet. I'll be 59 next month, so I've got some time left to go. But starting to think about those things. We discussed in some of the groups this morning the tremendous challenges that face mission hospitals to stay afloat financially while maintaining your ministry. When you give the ministry to a group and say, go take care of this group of very poor people, for the most part, that becomes a challenge financially, how to do that. And I think what shalom will look like is being very creative in the ways we're able to help people so that we don't turn people away who really need help. And we don't. If, for example, if you have an asymptomatic goiter that you want removed, you're going to have to pay before we'll do that. But if you have a goiter that's causing airway obstruction, we don't talk about money. We get you in the hospital and take care of you. Finding creative ways to make that work will be something.
Anybody with a question? Yes, Thomas.
Thank you so much, Doctor, for your talk today. Could you speak to some of the mentors and people that were really important in your educational experience that maybe put you on the right path? Maybe there are 1, 2, or 3 examples of people that played an important role in your own education and sent you on your mission.
Yeah, sure. There's a number of those I could speak about. Dr. Ernie Sturry was the first doctor at Tenwick Hospital, and when I went in '92, he was still there. He started in 1959, and in '92 he was still there. He was there up until the early 2000s when he retired and then eventually passed away of colon cancer.
He did about 40 years of every night calls, I remember. Yeah.
Yes, and he did call for the hydroelectric dam that he would have to work on. He did a lot of things, so he was instrumental. I mentioned to one of the groups this morning that when we decided, I was finishing my training, we were getting ready to head overseas, and somehow it came to me, I started to get job offers here in the United States. And looking at them, some of them were really lucrative. And I said to my wife, what do you think about the idea of maybe we take one of these jobs and we work for 4 or 5 years and get settled, and then we'll go over to Africa then at that point. She wasn't sure what she thought of that, but we went and visited a friend of mine who's a missionary surgeon to Nigeria and a fine Christian man, and I explained to him what I was thinking, and he said, so let me get this straight. He said, you intend to get your 401k in order and maybe your education funds for your kids, maybe a retirement home, something like that. You get all that done, and then you're going to go to Africa and trust God for the future. And I said, well, that doesn't sound very spiritual when you put it that way. He said, I can tell you many people who had that idea, and they didn't do it. Why? Because they were caught in the lifestyle they were in. They weren't doing bad things. They weren't robbing banks and selling drugs. They just weren't doing what they felt like God was calling them to early in their life. And so that made a real change. At that point, my wife and I said, let's trust the Lord. Let's go now and see what God will do. So those kind of mentors really make a big difference. I told Far when we agreed to go, I was to be one of 4 surgeons there. 2 of them were really quite experienced, had been there many years. And I was really excited to have surgical mentors. Those 2, as it turned out, did not continue at Tenwick. So when I finally showed up, it was me and one other person brand new, and we did a lot of reading of books and a lot of, I can remember distinctly, getting called for orthopedics, and I'd go look at the x-ray in the casualty department, go to the books and try to find an x-ray that looked like it and see what it told me to do. Many of those types of experiences that were, shaping in them, but I missed having a mentor at that time in my life.
I have to say, because I think it's an interesting part of the story, that one of those senior surgeons who left as Russ is driving up to Tenwick, he's in a moving truck pulling out. It's Dr. Michael Johnson, who was going to another area of Kenya where not long after Thomas Catena shows up as a family doc, and Dr. Johnson trains him how to be a surgeon. So it's just amazing how that worked out. Those
yeah, our loss was Tom Catena's blessing.
Yeah, and the people that Thomas Catena has been able to serve as well.
Yeah.
Yes, Jay.
thanks again for coming. I wanted to ask, after all those years of call and weekends, how did you not burn out?
Oh, I did. I burned out a couple of times. I'm not the best one to show the example of, but I do talk about it with our residents, and I try to be self-disclosing and say, here are areas that you should not copy me on. Don't copy me in how we did this, because this wasn't good. No, there have been times of burnout that have come, and it's only through appropriate care, self-care, and taking time. You know, surgeons, we don't talk about that much. We don't talk about appropriate self-care. That's for the family practitioners and psychiatrists to talk about. You know, we don't get into that. It's a challenge, and we all have to find that we're on a team together and watch out for each other, and try to help one another along. So, but yes, I've been there.
Yes, sir, right here.
Thanks for the amazing conversation. The case that you make for the phenomenal disparity in care in sub-Saharan Africa and around Tinmouth in particular is very compelling. But we don't have to go far to see disparities that are quite real. 3 times as many, perhaps, of African American women have significant complications in childbirth compared to white women here in North Carolina.
Right.
It's a phenomenal issue that is underappreciated by most people. Which of your lessons in your life could you share with others that are not called to international missions, but are called to provide health care as a physician or a nurse or a respiratory therapist or whatever locally, but feel compelled to address disparities?
Sure. Thank you for that question. There are certainly areas here in the United States, as we all know, that need help, need care. The numbers I presented were in broad strokes across the country, so that if we just, those examples of, we have 267% of the surgeons we need. If we spread them out, we wouldn't have trouble. Again, back when I was a medical student looking at surgeons in Ann Arbor, there's an awful lot of surgeons in Ann Arbor for a relatively small town. Now, of course, it's got a university, and there's all those other things that come into play there. But I would say to that, just like Jonathan looked and saw, I mean, when you look and see those problems, what is God calling you to do to be a part of the solution to those problems right here in North Carolina? I would assume God is speaking to you. Make that assumption. See the disparity, see the gifts that you have which can be used in that direction. It's not easy. It's not easy to start a clinic or things like that, but the Lord can bless those types of things that we do. So I echo your sentiments, and all of us should be involved in a ministry of reconciliation wherever we are.
Question here.
Yeah, my name is Nemeka Eze. I'm originally from Nigeria, and I grew up in a missionary establishment where I experienced people just like you who were making this sacrifice for our people. And thank you so much for all that you've done. And growing up there, I saw so many of the physicians come in and train local physicians to continue doing the work. You're not only giving people fish, but you're teaching them how to fish. Mm-hmm. And that's something I really want to keep doing. One of the issues I noticed was there was a significant dependence on foreign donations for medical supplies. Yep. And when you teach a person how to fish, how do we make sure they are able to keep fishing long after we're gone? And you know, one of the greatest quotes I've ever heard is, the richest place in Africa is not the gold mines or the oil wells, but it's in the graveyards, because there's so many ideas that never came to fruition. There are so many young minds who wanted to bring things out, and we didn't have an opportunity to really develop those ideas. As you build a cardiothoracic facility for really specialized surgery, one of the biggest challenges with this field that you're going into is how to get those medical supplies that you need to do specialized procedures, and how do you maintain them? So one of the questions I want to ask is, especially during the COVID pandemic, how did you go about getting supplies when supply chains were running out? And what do you envision for the future as to how we can develop Africa and the young African minds to go into developing low-cost surgical supplies that will help relieve the stress that dependence we have on donations, so that we can continue doing the work that you've trained us to do moving forward. Thank you.
Thank you for that great question. No, supply chains are critical. We often don't think of them, but for example, in cardiac surgery, if you're missing the circuits for the heart-lung bypass machine, which cost about $1,200 per circuit, all the tubing and everything that goes with it, or you're missing the heart valve, which on the open market costs about $6,000 or $7,000. We've been able to negotiate with suppliers, and we've brought that down to less than $1,000. But that's $1,000 is still a lot of money for many people. In Kenya, the average income across per capita is about $1,700, $1,700. So $1,000 is a lot of money. But you're quite right, and unless we are creative in how we develop supply chains, working with industry, realizing that we have to do that. I think historically, medical missionaries thought that was none of their business to get involved with, I'm not going to, I can't serve God and mammon, so I won't go speak to the industry people. No, you have to. You really have to. If you're going to serve God, you have to come up with a way to build that supply chain. And then, you face things like corruption in importations, and it can be a real disaster, a real quagmire to get yourself out of. But I think we have to recognize that and teach that, so that, again, my fellows spend a lot of time doing things that an American fellow would never do. They're on the phone with the supply companies. They're working out the details. They have to be able to do those things in order for this to be realized. But you're quite right in stating that Westerners, Americans largely, tend to come with money in our bag, and we're viewed as sources of money, and rightly so in some cases. But we have to enable partnerships to develop which are not dependent upon me as a Westerner being there, but true partnerships which can exist between the hospital and donor organizations. The self-sufficient mission hospital is kind of the holy grail of public health work, and I'm not sure it can be fully realized. Again, if you look at the United States, hospitals that serve the inner city, that are high trauma centers, they're not self-sufficient, not here in the United States. They have federal funding which allows them to go do what they're doing. Why would we think we could do that in the African context? We couldn't. But thank you for that question. I think we need to be very purposeful as we develop these situations and programs.
Russ, thinking of partnerships, it struck me that you had received a Surgeon of the Year award from the Surgical Society of Kenya. And then you have this teaching role in medical education role in the Organization of Central, East, and Southern Africa. What's that been like, the relationships with your African colleagues? And I guess, are you now accepted as an African physician in that context?
Sort of. I was born in Africa, and I've lived there all of my career life, but I'm still a Westerner, Again, that's something I think we should be purposeful about. Some of my colleagues in Africa disagree with me. They think we shouldn't be involved in the Surgical Society of Kenya and the College of Surgeons. That's secular. We need to keep ourselves pure and not have mission drift. Mission drift comes up all the time. And I say no, you have to be in the world. The scripture is very clear. We ought to be in the world. So we should be engaging with the Surgical Society, with the College of Surgeons, doing what we can to be a part of that fraternity to improve the situation and improve teaching, examination capabilities. I've seen the years I've been in the College of Surgeons of East Central and Southern Africa, tremendous growth, so that it's now the major certifying body in the whole of sub-Saharan Africa, the largest group that certifies surgeons. And I work with them. You know, some are Christians, not all of them, but we're all committed to those goals of teaching and training as well.
And do you expect with this heart center, when it's fully equipped and it's running, that you'll be training folks from other countries as well in sub-Saharan Africa?
Yeah, we've already started that. In fact, we graduated last year a surgeon from Zimbabwe, and he's challenged in his setup in Harare, but they are doing some cardiac cases. He's a fine young surgeon and a great Christian guy. So we've done that. We have a surgeon with us now finishing general surgery who will do cardiothoracic from Rwanda to try to help their situation. They have a team in Kigali that can do this. So I do see, and my vision would be if we're taking 2 residents, 2 fellows down the road, we would probably take 1 Kenyan and 1 from outside of Kenya. But you have to, again, cardiac surgery is different than so many other types because it's so dependent on the team. You know, you have to have the whole team present. So we're addressing that as well. We started the first perfusion training program in Kenya, is now underway at Tenwick. So those are the people running the heart-lung machine. We've got a program doing that. We're looking at training critical care nurses. You need all these pieces in place. So if you just train a surgeon and send him back to his country alone, it's not going to be very helpful.
Yes, question there. Is that Jeff? Yes.
Jeff is back here. Hi.
Hey, Jeff.
Yeah, thank you so much for your presentation. So I'm a historian, and I think your hospital motto has something that reminds me of what Ambrose Paré said, that I dressed him, God healed him. I don't know if that, well, maybe he copied you. But that comment to me is interesting because it's easy to focus on what happens with technology, what happens in the operating room. But you've also created an environment, and I would call it an environment of healing. Mm-hmm. And I've spent a little bit of time in a mission hospital myself, so I have some thoughts. But it's easy to say, what could a hospital, what could Tenwick learn from, say, a modern American hospital? Sure. But I'd like to reverse that question and ask, is there anything that our hospitals can learn from a hospital like Tenwick as an environment of healing? Does that make any sense?
Sure. Yeah, absolutely. Well, I think there's several areas. It's now appropriate, right, in modern medicine to talk about holistic health care, take a social history, take a family history, take all these things which need to be there. What support structures are in place for this patient that you're dealing with? The church should come into that. What is your church support structure? It may be nothing. There may be no church. But in Kenya, we're very attuned to that what is your faith, number one, because once again, in Africa, we understand there's a spiritual realm to our lives. We're not just a bunch of cells. We have a spirit within us. The West can learn from that. You're facing a struggle, of course, against that. But why would you not want to have a discussion about faith with someone in a holistic healthcare training model? That should be there. It should underlie some of it. So I think the West can learn from that. Can certainly learn the importance of the family and the community involved in somebody's health care. When someone has a need within the village or the community, there's a coming together generally. It's in Swahili, it's called harambe, which means people come together and help. And you'll hold a fundraising event within that village to help defray the costs. I think we can learn from that here in our country as well.
We're going to take 2 more questions. You can be next, yes.
Mzungu, that was fantastic. So I used to live in Uganda, and one of the interesting things is that a lot of times at the little Catholic hospital, that they would, the doctors would prescribe them to go sleep in the adoration chapel, wherever the host was being at the local Catholic church. And obviously in the USA, if I got COVID and they told me, well, go to Goodson Chapel and go sleep over there for about 12 hours and, that's part of your medicine. I was wondering, in your hospital over in Kenya, how do you handle those conversations in terms of faith healings and faith healers and being given almost doctor prescriptions of holiness or going holy sites or pilgrimage or things that you wouldn't necessarily see in the USA?
Sure. I've never prescribed somebody to go sleep in a chapel, but I have talked to patients extensively about their own faith and about how God can heal them. I gave that example of that little girl with the bean. That wasn't me at all. That was the Lord working to make that difference. Why God chooses to step in at times and other times he doesn't, well, that's a mystery right there. It's hard to wrap your head around at times. But no, we never want to discount. So our pastors and elders will come and anoint people and pray for them. They're not mutually exclusive endeavors. They are complementary endeavors. We'll do what we can medically, but we know at the end of the day it's God's strength and healing that comes about in your life. I think that's a holistic view of what healthcare ought to be.
Jerry, go ahead.
Thanks, Russ. Excellent talk, as usual. My question is about the trainees that you've trained for over a decade or more now, and their future. So where do you see the trainees are being trained in Tenwek for CT surgery and other programs? Do you have capacity? Have you reached capacity at Tenwek? Do many of them end up in mission hospital settings, or are they engaging in other hospital spheres in Kenya or other places?
Sure. With CT surgery, you're limited to practice in a place that has the capabilities, that has all those things that I showed. Otherwise, you won't be able to utilize your training. Thus far, we've kept 3 of the surgeons there at Tenwek because we're planning for the future with this building of needing that number. By the way, I need cardiologists, so if you know any, I know Jerry's one, but I need plenty of cardiologists. Usually, there's about 5 or 6 cardiologists for 1 CT surgeon. That's kind of the numbers that we would look at in the United States. We're going to have 5 CT surgeons and no cardiologists, so we're backwards from where we really ought to be. But in our other areas of surgery, our students go to a lot of different places. Just very quickly, I mentioned to the group this morning, there's a smaller mission hospital about 40 miles away from us, and they are with the African Inland Mission. We thought they really could use a surgeon. They balked at that. They were using a locum surgeon, which is really not a good idea because things would wait and be delayed and not taken care of well. So we actually had to speak to the board of that hospital to push them to take one of our surgeons, which they did, and they were so pleased they hired 2 more. So they now have 3 general surgeons and 1 orthopedic surgeon at their hospital, and they've started a PACS training program. So they're running a new residency completely. There's no missionaries involved in that endeavor, and they're running a residency program. That's really gratifying to see. There's another one in Chogoria Presbyterian Hospital over towards Mount Kenya, and one of our graduates, the 2nd year of graduates, he's there and he's running a PACS training program as well. So those are really gratifying to see those kind of things develop. And people go to a lot of different, people are in some teaching centers, some mission hospitals, some government hospitals. But we feel like we're having an influence across as people are scattered to these different places.
Russ, I'll just ask you a last question, which is, people say, this is compelling, what do you need, how can we help? What would you say?
Well, I've said find me cardiologists who want to come work at an exciting new cardiothoracic center in Kenya. That would be wonderful. I think how else you can help, there are people in this room who are supporting the PACS program that trains surgeons, and that's the Pan-African Academy of Christian Surgeons, which we are a member of, which helps provide administrative oversight and some financial coverage as well for the costs involved in training of surgeons in that particular area. Certainly keep us in your prayers in what we're doing. The building I showed you is fully funded. We were able to raise the funds at $34 million, and it's fully funded. The equipping of the building is not at this point. So that's what I'm spending my time trying to raise funds. We're looking at a budget of something like $15 million to outfit that hospital. And so I'm waiting for the Lord to, so I would tell you, you can do one of two things. You can commit to pray for us fervently that the Lord would provide that funding that we need. Or if you don't want to do that, you can write a check for $15 million. And either one of those would be really helpful.
One of the things I love about surgeons is they're very clear and decisive. It's been delightful to have this evening together. I want to say we are going to move to the veranda here, just down this hall and to the left, where we have a reception. You're all welcome to stick around, talk with one another, talk with Dr. White. Thank you again for coming, and please join me again in thanking Dr. Russ White.